Hello, today I'll be speaking, discussing the brief history of cardiovascular advances at the University of Minnesota. I'm Paul Iazzio. I'm a professor in the Department of Surgery, also the Associate Director for the Institute for Engineering and Medicine. And joining me today is Dr. Tinen Iles, who's an assistant professor in the Department of Surgery as well. We are both from the Visible Heart Laboratories, which is a laboratory within the Department of Surgery. These laboratories are located in the basement of the Mayo Building or on the first floor. These are the same labs where a lot of these pioneering surgeons that we're going to discuss their research and successes worked in many years ago. So it's very inspirational to work in these labs for our staff. You can see here, and the 10 current PhD students that are working in our lab. We have a number of master's students in the lab as well and a cardiology fellow. Our goal of our lab is really to train the next generation of medical device innovators, and it's inspirational to be in the same space where these pioneers first worked. If we look at the brief timeline of some of the cardiovascular firsts at U of M, I'm not, of course, covering all of them because there's many. I'm relating more of those that are associated with the Department of Surgery. We can look at the first attempts for open heart surgery, which were done in 1951 by Dr. Dennis with a prototype heart-lung machine. Then in 1952, they successfully did the first ASD repair, or atrial septal defect closure. That was done by Lewis and Varco using deep hypothermia. This is the first open heart surgery where they had direct visualization of the defect within the patient's heart. Subsequently, they moved on to use cross circulation, and I'll be describing and we'll be showing videos of this throughout this presentation. They did the first successful VSD closure in 1954. That attempt was on March 26th. Patient lived for a month and then died of pneumonia. The second VSD closure, the patient survived for 64 years, and we'll be discussing this case in detail. AV canal corrections were done with cross circulation by Lillehei and colleagues. They did the first ever tetralogy of flow correction anywhere in the world at the university. And then in 1955, Dr. DeWald, working with Lillehei and others, were able to get a working heart-lung machine. This was called the bubble oxygenator. And there were disposable components. And we'll have videos showing this technology as well. With this, they were able to do a number of different procedures. Then they realized that in some cases they needed pacing. This was first done by Gott and colleagues with epicardial pacing in 1957. Then the first wearable pacemaker developed by Earl Bakken was utilized in 1958. And subsequent to this era then, with working heart-lung machines, pacing, and other capabilities, the field of cardiovascular surgery really took off. And then next big step was using implanted mechanical valves to treat valve disease. The Lillehei Heart Institute was created in 2001 to honor the accomplishments of Dr. Lillehei. Our lab first put on the Atlas of Human Cardiac Anatomy online in 2005. And then we initiated the Bakken Surgical Device Symposium in 2007. Why did this happen in the 50s? Well, World War II was the first war where they actually had surgical field hospital units there. This means that the surgeons were right on the battlefield with blood products. This was first developed by DeBakey, and this lasted from September 39 to September 2nd, 1945 during World War II. And it is noted that Dr. Lillehei was a field surgeon for 2 years in one of these units during World War II in North Africa and Italy. It was these experiences that these surgeons had that really motivated them to come back and pursue cardiac surgery. The philosophical thought at that time prior is that you couldn't work on the heart without killing the patient. But this experience during the war where soldiers came into these units with shrapnel right through the chest wall into the heart, they opened them up, sewed up their heart, gave them blood products, then they lived, changed all that. And this is where there was a big push then after World War II to advance cardiac surgery. So if we look at just in 1951, if you had a congenital heart defect, that caused 1% of all deaths in the US. The prognosis was extremely poor. There was really no methods for doing a surgery within the heart at that time. Only simple surgeries were performed on beating hearts where they weren't opening up these individuals' own hearts to do the repairs. The advances happened in Minnesota in cardiovascular medicine for a number of reasons. One of the reasons was it was the place in the United States where they had the first dedicated heart hospital, the Variety Club Heart Hospital, which was founded in 1951. And then there was budding medical device industry also occurring in Minnesota.
Variety Club Heart Hospital, devoted entirely to the study and treatment of this one organ. In the mid-1940s, Dr. Morse Shapiro, a pediatric heart specialist, saw the need for special facilities to treat children with rheumatic heart disease or congenital defects. He discussed the need with one of his adult patients, Al Steffes, a member of the Variety Club, an organization of show business people whose guiding purpose was to help disadvantaged children. Steffes brought the problem to members of his chapter, Tent 12, the Variety Club of the Northwest, and the idea of a heart hospital was born. Entertainment people from across the country got involved to raise money for construction and support. The hospital was dedicated in 1951, and thereafter seemed to become a magnet, drawing to itself some of the best and brightest surgeons, scientists, and medical people in the country.
All right, as I mentioned, there was a budding medical device industry. If we look at 3M, they were making adhesive surgical drapes back in 1948. Just down the highway or southern Minnesota, we had the Mayo Clinic. The University of Minnesota has had a partnership with Mayo since 1911. There's a video showing the dedication of the Plummer Building in 1927, and you can see a lot of surgical advances happened at Mayo, and via the partnership with Mayo, the University surgeons and Mayo surgeons really worked together to advance both candidiac surgery as well as surgery in general. The department during this era was under the leadership of Owen Wangenstein, who was the chairman of the Department of Surgery for 37 years. He became chairman at age 30, making him one of the youngest surgical chiefs in the nation. Basically, he was a dynamo. He really moved this department, built this to be one of the #1 departments of surgery worldwide. He had an innovative approach. So he created this innovative atmosphere for all his surgeons. So he had this very unique surgical residency program. There were international collaborators coming in. There were mandatory informal weekly meetings. There was the cooperation with the Mayo Clinic. One of the unique things he did is he required a lot of his surgeons to get a PhD as well. So they were all MD PhDs. That means they had to be in the research labs, down on those same labs where the Visible Heart Lab is today, and pursue research relative to a thesis project.
Dr. Owen Wangenstein. Wangenstein felt that doctors should be more than just good practitioners. They should also be well grounded in basic science. They should be not only surgeons, but also surgeon scientists. He encouraged, even insisted, that doctors devote some part of their time to basic research in the lab. In this push toward investigation, he was joined and supported by Dr. Cecil Watson, the head of medicine, by Dr. Irvin McQuarrie, the head of pediatrics, and Dr. Paul Dwan, a pediatric cardiologist, by Ray Amberg, the director of the hospital, and by Dr. Morris Vischer, who both consulted with residents and doctors and made his physiology labs available to them. Together, they nurtured the belief that with enough time, study, and perseverance, almost any problem could be solved. In the words of Dr. Wangenstein, the only limits on your achievements are the limits you place upon your imagination.
As noted in that video, one of the key figures was Maurice Vischer, who is the chairman of the Department of Physiology for over 30 years. Eminent cardiovascular physiologist. He actually worked with Dr. Starling, the famous Starling's Law of the Heart. And so he opened his doors for these surgeons. And at that time, it was really the physiology labs where they had a lot of equipment necessary to do monitoring and testing of the heart, which then could be utilized for cardiac surgery. So this was a critical partnership for a lot of these cardiovascular advances that we see today. All right, so beyond Professor Vischer, there was important cardiologists that were also played a key role in this.
Pediatricians, Doctors Ray Anderson, Paul Adams, and Forrest Adams, begin work here on techniques for more precise diagnosis of heart problems. They collaborate with Dr. Kurt Amplatz, who is in the forefront of work on cardiac catheterization. As a team, they develop new equipment and techniques for measuring pressure and oxygen levels by inserting a catheter into the heart.
So again, this period of time, if we're looking at a patient with a congenital heart defect in the 1950s, basically, if you even had a defect between your atria or an atrial septal defect, you were lucky if you reached the first grade. Today, they're doing these kind of repairs in utero or immediately after birth. So the advances that have happened since 1950 are just phenomenal.
Prince Dennis has been developing a heart-lung machine for several years. Now he is ready to use it on human patients. It will be a first in medical history. He performs 2 operations, but there are complications, and neither patient survives. Further attempts are postponed. Similar operations are performed at other centers, also unsuccessful.
So this just notes that there were efforts worldwide to develop heart-lung machines out on the East Coast, down at Mayo itself, but again, in 1951, nothing was successful. That's when they went to use deep hypothermia, which would be cerebral protective for those patients. There are many reports throughout history of people drowning in cold water. They're being resuscitated and without any neurological deficit. So that philosophy then was used for these open heart surgeries. This was first attempted successfully then on September 2nd, 1952 by Lewis and Varco, and the second assisted, notably, one of them was Dr. Lillehei.
Dr. F. John Lewis performs a heart repair on a child by dramatically lowering her body temperature to slow her metabolism, allowing blood flow to be stopped long enough for quick surgery to close a hole inside the heart. The operation is a success. They are able to go on to repair certain congenital heart defects in several more patients. But accurate diagnosis is a major problem. Dr. Lewis finds too often, once inside the heart, that the defect is not the one diagnosed and cannot be repaired in the time available. Hypothermia proves to have limited application. Nonetheless, the news of these successes spreads worldwide.
Also should be noted at this period of time, the imaging was limited. X-ray machines weren't portable, and basically there were no clinical defibrillators available. So these are key factors today. We know what the defects look like with careful echocardiography or CT imaging. And if the patient's heart fibrillates, and they still use deep hypothermia today when they worried about cerebral protection, they cool it down, the heart warm it back up, it might fibrillate, they can just quickly now shock it back.
This is original footage of an open heart procedure which took place 1 month later, in October 1952. The superior and inferior vena cavae are encircled with tapes. The aorta is also circled with tape to control air embolism. The patient, a sickly 7-year-old girl, is anesthetized and wrapped in a cooling blanket. Refrigerant circulates through the blanket until rectal temperature reaches 28 degrees centigrade. The cooling blanket is then removed.
So again, they were doing major advances just even with deep hypothermia surgery. They first started packing these patients in ice, and more ice if it was a bigger patient, and then they used cooling technologies. If we look at the operating room back then, there were really no computers, no digital equipment existed. There were glass thermometers, blood pressure cuffs. Often you press the finger against the wrist to record the vital signs and heart rate of the patient, just as I could do now. You'd use the second hand on the clock to look at heart rates. Anesthesia was still not well advanced either. They still had to hand bag these patients. Sometimes these anesthetics were explosive. There's stories of patients and surgical teams blowing up in the ORs. And again, the X-ray was not portable. Headlamps were used. Very different than any OR you would see today. This is a video showing this minimal equipment. There's Dr. Lillahai helping with one of these deep hypothermia studies. You can see the cooling blanket being applied. Again, this was an advance over the ice where they could better control the induction of the deep hypothermia. And then they're using a rectal temperature probe. They're connecting here. And then they had state-of-the-art recording of the temperature using analog recording systems. And if you ask most teenagers or people in their early 20s what an analog system, they probably have a hard time explaining that is. But it's going to be shown here briefly in the video where you've got a motor, you have a paper connected to the drum motor, and this tracks a pen over that, and there's your 98 degrees centigrade. They turn on the cooling, and they're dropping the core temperature down. So they know what at that point when they're ready then to open up the patient. There's the hand bagging of the anesthetics. Again, just showing how minimal the equipment was in these rooms. A lot of these rooms didn't even have EKGs at the time. They were just beginning to use electrocautery. The problem with rewarming these patients, as you cool down the heart and warm it back up, it can become irritable and might fibrillate. And so this patient now just had open heart surgery, and you're warming them back up from this 29 degrees centigrade. And how did they do this? Well, this is how they started.
The chest wall closed, the patient is immersed in a bath of water about 114 degrees Fahrenheit to warm her. In 35 minutes, her rectal temperature reaches 36 degrees centigrade, and she is removed from the Sears Roebuck cattle watering tank.
So again, they're hoping that there's no fibrillation, and if there is, they don't really have clinical defibrillators, so then they would have to do CPR or give drugs such as adrenaline, and if that didn't work, open up the chest and do cardiac massage. It's a picture here of Dr. Lillehei. He's today still considered the father of open heart surgery. Interestingly, he came to the University of Minnesota at the age 16 to begin his undergraduate work, entered medical school at 19, then proceeded to go to World War I from 41 to 40, after 1942, after he did his internship. Was there for 2 years, like I mentioned, in North Africa and Italy. Came back motivated to really do cardiovascular surgery, and also finished a PhD in the Department of Surgery. He actually was diagnosed with lymphosarcoma in 1949, and actually Dr. Wangenstein did his surgery. He survived and lived till 1999.
Well, I trained in my surgery at the university after World War II. I returned from that service, and during the training period, we were doing 8-10-hour operations. That is, Dr. Wangenstein, who was the chairman of the Department of Surgery at that time, was very interested in cancer and was doing these long, complicated operations. The blood transfusions were readily available, and we had antibiotics, penicillin in those days. But I was struck by the fact that people were dying with a little hole inside the heart that any seamstress could have sewed up in a few minutes if you could get the heart empty of blood and have a chance to work on it.
Important thing when they got these patients without the imaging is be prepared. One of the ways they prepared to predict what these holes might look at, they studied pathologic specimens. They went down to Mayo, and Dr. Jesse Edwards, who was a pathologist there, had an amazing collection of congenital heart defects that he preserved. And basically, the stories are Dr. Lillehei and his colleagues would go down on Saturdays, study all these specimens, study all the potential congenital heart defects that they might observe. And this actually, heart registry now is over at United Hospital. It's known as the Jesse Edwards Registry of Cardiovascular Disease. And they have tens of thousands of specimens there. Similar to that, the Visible Heart Lab has also developed a library of human hearts. Not all congenital defects. These are more typical adult human hearts that we receive fresh, unfixed. We'll then cannulate them and under a pressure load dilate them to hold an end diastolic shape. And so we've created a library as well. That means that any student, any academician, anybody from any company can come to the Visible Heart Lab and study these specimens. And we can make 3D models of these as well in 3D prints. So here's a picture of Dr. Lillehei performing preclinical research within the Department of Surgery research laboratories, or the dog labs as he'd like to know them, which is the basement of the Mayo building. It's where experimental surgical services was, and then we moved in almost 20 years ago. And it's the labs where Dr. Lillehei and colleagues worked on developing methods for cross circulation, as shown in the next video.
Use another dog to circulate blood for the patient dog, much as a mother's heart pumps blood for her unborn child. And after a number of successful operations using donor dogs, they observed something else. Both patient and donor dogs suffer dramatically fewer side effects and recover more quickly than with any other extracorporeal circulation experiments they had tried. Is it time to try this technique on a human patient?
So again, with a limited number of preclinical studies, things advanced quickly during this era, and they went then and moved on to patients. So the first attempt was March 26, 1954, right in the Mayo building on the 4th floor, which used to be the old operating rooms before the new hospital opened in the early 70s. This was a 1-year-old patient. So surgery was successful, but she later died of pneumonia. and they actually did 45 cross-circulation procedures at the university. Important thing to note in this picture is there's actually 2 patients in the same operating rooms and 2 surgical teams, one managing the donor and the other managing the patient with the congenital heart defect. So again, this was a very novel procedure. There was a lot of naysayers for this as well, or detractors. William Potts said this would be the only surgery or operation where you could have a 200% mortality. And this was a different era again. So the FDA was founded in 1938, but didn't cover medical devices until 1976. So in this era, there was not institutional review boards either. You actually had to get permission just from your chairman. So Dr. Lillehei talked about his successes to Professor Wangenstein, and then asked his permission. And the story goes, there was a written note for him, "Dear Walt, by all means, go ahead. Good luck, OHW." So then they performed this pioneering surgery on March 26th.
Clinical cross-circulation for intracardiac operations was an immense departure from established surgical practice. Taking a normal human being to the operating room to provide a donor circulation was considered unacceptable and even immoral by some critics. However, the heart surgeons at the University of Minnesota hospitals suspected that total body perfusion with open cardiotomy caused massive physiological disturbances. Temporary placental circulation could minimize or even correct these disturbances. Centers around the world working on heart-lung bypass were having no success. So the Minnesota heart surgeons decided to go ahead with cross-circulation technique, even though critics pointed out that this was the first operation in medical history with the potential for, as they said, a 200% mortality.
This next movie shows the procedure itself.
Dr. Lillehei and his colleagues performed all these cross-circulation operations at normal thermia. Headlight use became routine after the first operation. Doctors Morley Cohen and Herbert Warden, surgical residents at the time, managed the donor during all these procedures. The chest was opened by transverse sternotomy. Cannulations were completed, cavitae were occluded, and then the right ventricular cavity is opened. Note the very thick right ventricular muscle due to the hypertrophy. From this view, the 20-month-old patient is flat on his back, his head to your left, feet to your right, with the right atrium in the foreground. Using a forceps, Dr. Lillehei picks up the edge of this. Once all sutures are placed, the left atrium and left ventricle are filled rapidly with 5% glucose to displace the air as the stitches are tied. The heart beats without any evidence of heart block. Closure of the right ventriculotomy is carefully done with a full-thickness 3/0 stitch. The cable occlusions are released and the patient is returned to his own circulation. 8 stitches close this ventricular defect. The patient had a pump bypass interval of 12 minutes. Total body flow was 300 cc's per minute, equal to 30 cc's per minute per kilogram of body weight. Palpation confirms the absence of any palpable thrill in the pulmonary artery segment. The infant's mother was the donor. The patient is seen here 10 days post-operatively, a bit subdued, but very viable.
Dr. Lillahei and colleagues, Cohen, Warden, and Varco, with their pioneering advances in cardiovascular surgery using cross-circulation, in 1955, received the Albert Lasker Clinical Medical Research Award, which is a prestigious award for medical advances. And this is a short video of them discussing their technologies.
The past 15 years, tremendous advances have been made in cardiac surgery. However, there's remained one barrier which has been most frustrating to those surgeons interested in this aspect of surgical treatment, and that was our inability to work within the heart in a relatively leisurely fashion with the heart open and free of blood, and thus correct certain intracardiac lesions which at the present time were hopeless or at best subject only to palliative operations. Those of us here have been dedicated to the principle that there must be somehow a simple method for accomplishing this intracardiac surgery under direct vision. Progress really began to be made in this field about 2 years ago here when Dr. Morley Cohen on my left and Dr. Herbert Warden began to work full-time in the laboratory upon this problem. The final form is Dr. Cohen's suggestion, and I'll ask him to describe it.
Essentially, the unit which permits this method of intracardiac surgery, which is basically one of cross-circulation, is made up as follows. We have a motor here on the left which activates the entire system. We have a gearbox interposed here which regulates the speed and consequently the amount of blood pumped during the procedure, and finally the pumping mechanism itself. The entire system has only two controls, a regulator on the gearbox for the speed, and finally a switch to turn the mechanism on and off.
Arterial circulation of the patient. The patient's used venous blood is returned through this tube, through the pump, and back into the donor's circulation for reoxygenation and recirculation.
So again, this was pretty amazing. This was performed, these cross-circulation experiments by Dr. Lillahei and his colleagues. And again, the first successful VSC repair anywhere in the world was performed on April 20th, where they had long-term survival on Bradley Merman. And this was described in the book by Daniel Gore, The Genius of C. Walt Lillahei and the True History of Open Heart Surgery. Next, I'll turn over the podium to Dr. Iles to describe this particular case.
Well, thank you, Professor Iazzio. And, we were really honored to have Bradley Merman donate his body to the Visible Heart Laboratory and part of the Anatomy Quest program at the University of Minnesota. And so this was, again, a real honor to us to receive his body and to do a lot of the imaging and to do pre and post mortem data. So we were able to collect a lot of the data that he had clinically prior to his death, and then also combine that with some work that we had done in the lab. And so we did in-lab fluoroscopy, and we also prepared the body to do a full CT scan, computed tomography, in which we could create models of the heart and 3D prints. We'll kind of go into a little bit more of that as well. But then again, going through and doing an educational dissection and removing the heart for perfusion fixation. And then re-scanning the heart and doing some additional imaging of that as well. We also, after we perfusion fixed the heart, did endoscopic images where we were able to actually directly visualize a lot of these the CHD lesions, and also preparing that for the Atlas of Human Cardiac Anatomy, which is the website that is hosted by the Visible Heart Laboratory. And we recently published this in the Annals of Thoracic Surgery. And so the co-authors on this paper was myself and then Mikhail Holm, who is getting her doctorate in biomedical engineering in the Visible Heart Laboratories, and also had Dr. Andrew Calvin, who is a cardiologist at Mayo Clinic and was the donor's cardiologist towards the end of his life. We also had Dr. James Moeller, who's now an emeritus at the University of Minnesota from the Department of Medicine, but was his cardiologist at the age of 3 during some of these initial procedures. And then Professor Iazzio, who did a lot of the dissection together with myself and a lot of the imaging, and we put this together in a publication, just highlighting both the history, but then also going through and showing some of the biomedical engineering principles that we're using in order to really preserve the anatomy and the story. So again, this is the second cross-circulation patient and really the world's first successful VSD closure. And we have a combination of records that we got from the Mayo Clinic and that we also went to the libraries of the University of Minnesota and went through a lot of the archives there and were able to obtain some of the imaging, some of the other images, and then also some of the other paperwork from that we were able to collect and kind of curate. But this is the actual operating record from April 20th, 1954. And it just really, we here in the signatures, again, these are the kind of the key players, Lillehei being the surgeon, and we also had Barco, Cohen, Austin, Stutzman, who were also part of the surgical team at that time. And I'll go through in a little bit more detail about some of the kind of like really more interesting facts that we found in the surgical record. But I'll first just say too that we had a really unique opportunity that the family of Bradley Merman came to visit the lab and really spent the day with us talking about Brad talking about himself and just some of the memories that his sister had of actually this whole like the emotional piece of this and how really deciding that his father was going to be the donor and that was at the age of 25 and they had other children. And again, going back to this kind of fear that there is a possibility of a 200% mortality, and just a lot of the other kind of things that went along with that decision-making process was really really inspirational and interesting to hear. So from the surgical records, the surgery took 51 minutes from the chest incision opening to the pericardium, and it was quoted as being considerable difficulty after opening the heart because there's a regurgitant flow of the VSD. So the surgical field was really difficult to really see. The VSD itself was estimated to be about 1 3/4 of a centimeter. And this was really of interest to note that they were having to pinch off the aorta for a minute or two at a time and really to be able to visualize the surgical field and to really see what they were doing, what they were stitching. And approximately the person describing the surgical records documented that there was about 4 to 5 sutures that replaced actually closed the defect, and because of the visualization problems, there was a transection of the anterior papillary muscle, and that was also sutured prior to actually closing the incision. So the total on pump time from the father to the donor was 27 minutes and 20 seconds. And that really is pretty incredible to think about having the father and the son being oxygenated by his father for that period of time and really being the first successful, long-term successful outcomes from this. And this is another kind of quote. This was another quote from the surgical records. Lillehei described that the heart action at first was slightly weak, although regular, and it was watched as it picked up bigger, and there was no additional need for any sort of drug. So there was no other epinephrine that had to be given for this in order to actually get the heart beating again. And here's just a few more details of the surgical procedures that the donor had over his lifespan. So again, he was 3 when he had his first procedure done by Lillehei and team, and then had several other procedures, both open heart procedures and then also intravascular procedures done before his death at the age of 67. So Lillehei did his first procedure in 54. Again, that was for the initial VSD closure. And then he also did a secondary procedure on him in 1963. But at this point, there's cross-circulation wasn't being utilized, and so he was on a blood oxygenator. And this they went back and did the surgery because of a recurrent shunt. And this, there's also some other issues with that transection of the papillary muscle that caused for a lot of regurgitant flow into the right atrium, and so that the right atrium became very enlarged over time. So then he really didn't have any a need for any additional procedures until the age of 46. And so at that point, they had enough regurgitant flow through the tricuspid valve that they felt that it was necessary to actually place a mechanical valve, and so they placed a St. Jude bileaflet valve in the tricuspid position at that point. And again, it was on extracorporeal circulation. And this was a gold membrane oxygenator and cardioplegia arrest. So this is, again, just like from a historical perspective of the evolution of the surgical procedures themselves. And then in 2015, at the age of 65, he was having some issues with syncope and pauses, and so he had a pacemaker implant. And this is, I'll show the imaging in some of the next slides, but really I'm looking at some interesting use of using both for CRT or cardiovascular synchronization therapy, and then the single leads going through the coronary sinus because of the inability to really go through that St. Jude bileaflet in the tricuspid position into the right ventricle. And then towards the end of his life, he had AV nodal ablation, which didn't seem to really, at that point, he was kind of an end-stage heart failure and wasn't able to really recover from. But I will also note, too, that his family really described him as an outdoorsman and really had a, he spent a lot of time outdoors and with his family and really had a high quality of life had a high quality of life. So really it was quite amazing to look at some of this imaging, that he was able to live this long and be so active over this time. On your right hand side of the screen, on April 23rd of 2018, this is from Dr. Calvin, shared these images with us. But he had some chest x-rays to kind of check in on how things were going, and this is a picture of his heart, and you can see that it's taking up most of the left hand side of his chest. And when we had his heart in our laboratories, it weighed 1,447 grams, which is an extremely large heart. And I'll play this fluoroscopy image here. And so this was post-mortem that we took in the laboratory, and you can see that he had the wires that were closing his chest from the median sternotomy, and then also in the St. Jude bileaflet in the tricuspid position. And then you also have the leads. So that was the pocket for the leads, and then the initial lead, and then the CRT that was placed through the coronary sinus. So then we also had this opportunity to do a computed tomography of his entire body utilizing the Fairview Hospital scanner. And so we started from head to toe, and at that point we injected contrast through dissection ports that we had put into both the femoral veins, arteries, and the jugular and the carotid, and injecting large amounts of IsoView contrast. And so then we were able to see here that we were lighting up the vasculature, able to create these blood volume models and imaging of the whole body. But from this, then we will use other methods in order to create the models and then for the 3D printing. And then as part of this dissection, as Professor Iazzio mentioned, we did this whole educational dissection of the donor. And we'll just note here that we were just observing some of the larger scars that were made on the exterior surface of his chest. And then we also isolated his heart and also perfusion fixed this in an end diastolic state so that we could visualize the internal anatomy. And so here's some of the images that we took from that. So this is a videoscope or an endoscopic camera that was placed into the right ventricle. And we're looking at the BSD closure from the right side on the right ventricle. And you can see There's part of kind of like this papillary muscle and this incision from the 4 to 5 sutures from the initial closure that Lillehei did in 54. And then on the left hand, or for the VSD closure from the left ventricle, you can see that the incision is probably looks more clean or sutured because the other side, we were doing the sutures from the right hand side of the ventricle. We also took some additional external images. This is from the fresh images that we obtained via the superior vena cava. So this is looking down the superior vena cava and then at the mechanical bileaflet, and then this is also from the perfusion fixation where we're visualizing that placement. And that was, again, done when he was 46 years old. So then eventually the patient required pacing system. So there's an original lead that was placed through the anterolateral vein in order to obtain pacing, and then it was later decided that there was a CRT organ cardiac desynchronization therapy pacing system that was needed, and so a Medtronic quadrupolar LV lead was advanced through the great cardiac vein and anchored in a distal tributary. And this allowed for CRT pacing through both of these lead systems. You also notice that there was large encapsulation of these leads, as directly visualized in the right atrium, and those leads again are going into the coronary sinus instead of through the tricuspid valve because of the mechanical valve that was placed. So really, a lot of the unique pieces of how we were able to immortalize this story too is creating these images from the CT scans. We use a materialized mimic software, and we're able to threshold and create these masks of the different blood volumes and a lot of the other anatomy. And then we can create different models and prints and use that both for teaching and education, and also for telling the historical perspective of the story of the first ventricular septal defect closure. And these are a couple images that we have from the paper as well, but you can see too in figure A, we have both the venous and the arterial system in the left and the right hand side of the heart. You'll just notice how large the heart is and relative to the lungs, and so really the ventilation of that left lung was very minimal towards the end of his life. This is the heart that we 3D printed, and you can see the inside. This is the right ventricle and the left ventricle, and you have the pacing leads in the tricuspid and the mechanical valve in the tricuspid position. And this is a very large heart, and this would be more of a normal sized ventricles and full heart, and this would be a normal sized heart, and you'll notice just the difference in the size of the thickness of the ventricles between a normal heart and the donor's heart over a period of time. And so that I'll pass it back to Professor Iazzio.
Well, thank you, Dr. Iles. Tinen, that was fantastic. And again, Mr. Merman was very honored to be this first successful VSD patient, and actually always wanted to tell the world, as his family mentioned to us. So we want to continue his story to honor his requests. Again, a lot of rich history from Dr. Lillehei. Dr. Cohen was quoted in the book by Daniel Gore to say it was just amazing to be in the presence of Dr. Lillehei, watch his work, and he had this immunity to hysteria that allowed him probably to proceed on and be this maverick in cardiovascular surgery and move the field forward. And again, he is known as the father of open heart surgery today. Again, as we move from cross circulation, which Dr. Iles nicely described, one of the patients, in 1955, we had the bubble oxygenator. And this was developed by Dr. DeWald along with Dr. Lillahai and the rest of the cardiac surgeons. They all worked together as a team. They worked with the physiologists. They worked with engineers at the U to develop this apparatus. So then, if we look at the OR in 1955, when we have these first surgeries with the bubble oxygenator, we can see there's just now one patient in that operating room and this working heart-lung machine.
In this extracorporeal circulation hookup, the patient is on the left, the Sigma motor pump for cross-circulation is in the center, and the disposable bubble oxygenator is on the right. Operations were done under normothermia. The oxygenator reservoir is immersed in a water bath to control temperature deviations. This blood rises in the oxygenator mixing tube, enters the transverse debubbling chamber, and then into the final debubbling in the helix reservoir in this 1955 model of the DeWalt-Lillahai helix reservoir oxygenator.
This original system is down in the Variety Club Heart Hospital. That's where cardiology is located today. So if you want to take a look at the system, it's still there today.
The DeWalt-Lillahai bubble oxygenator was an instant success where it was tried. And the revelation that open heart surgery could be carried out with a few lengths of plastic tubing, some clamps, and some oxygen had an explosive effect on the growth of open heart surgery worldwide.
In 1956, a commercially manufactured oxygenator was developed by Gott, DeWalt, and Lillahai. This self-contained unitized plastic sheet oxygenator facilitated open heart surgery applications. The surgeon's dream of routinely performing intracardiac correction in the open heart had become reality.
So this shows the revolutionary design, meaning that they borrowed most of this equipment here shown on the right from the preclinical research labs. They got some sterile tubing, and then they brought it and used it on patients. And then this other picture here on the left is the one where we have Dr. Gott showing off the commercial design. You know, catheters were used. This era, it's kind of interesting how inexpensive these were. You could buy, you know, a dozen of these catheters for the bubble oxygenator for $32. Interesting, checklists were still used or initiated back then. They're used today, I should say. And they had you know, this is important to have all this to make sure all this new equipment, all this new engineering technology was used properly in the operating rooms.
A third milestone operation depicts using the disposable bubble oxygenator. In 1955, this 7-year-old girl was carried into the heart hospital by her parents for intracardiac correction of the tetralogy of Fallot defects. Before corrective surgery, the girl is severely incapacitated by dyspnea, extreme cyanosis, and episodes of syncope. Her hemoglobin is 27 grams, and her hematocrit is 82%. Her paternal twin sister, with a normal heart, weighs 56 pounds. The patient weighs just 36 pounds. Her X-ray is typical of severe tetralogy of Fallot. Anemic lung fields, the usual heart silhouette of right ventricular hypertrophy and sparse pulmonary vasculature, and the concave pulmonary artery segment is evident. Because of the frequent similarity between the clinical signs of tetralogy and other forms of cyanotic heart disease, the Minnesota heart surgeons learned it was wise to perform a forward angiogram to confirm the anatomy of the great vessels. This tiny pulmonary artery segment, anterior to the aorta, confirms the diagnosis of tetralogy.
So again, today, these patients would be treated shortly after birth here at the University of Minnesota in the Masonic Children's Hospital. And they wouldn't get to this stage where you would see this dyspnea, excuse me. They wouldn't get to the stage where you could see the severe cyanosis. Interesting side note, one of the early VSD patients that was on a bubble oxygenator was my own cousin, John DiOrio, still alive today, lives down in Houston, and here he is showing the Variety Club Heart Hospital. There he is leaving with my uncle. So it's pretty amazing that even in my lifetime, how cardiovascular surgery has had major advances.
And the first 70 cases, we had 7 heart blocks. There was no treatment except people said give adrenaline. Well, adrenaline speed up the heart, but a little bit of adrenaline, a little overdose, the heart would be going 200, 250, and you'd shut it down and the heart would go to 50 or 40 or 30 or stop. Adrenaline didn't work. We couldn't keep them alive for any length of time. So all of those 7 died. And that was a devastating complication to us. And that's when the crash program began in the dog lab on some means of treating the heart block. And we tried to, well, I first met Earl Bakken because he appeared one day and Ms. Schultes, the supervisor of these operating room suites, introduced me to him, and it was her response to some vigorous, vociferous complaints of long standing. I think 6 months or more, we started open heart surgery with a heart-lung machine, the bubble oxygenator, in 54. And this was sometime in late 54 or early 55 that Earl appeared. And my problems were in the operating rooms here. Once you started anesthesia, there were a dozen pumps and suction machines and special lights with 60 cycle interference. And so electrocardiogram was a very important aid that sat beside the patient that we could get strips off of the heart rhythm to, in those days, diagnosis was quite primitive, as was the surgery. So frequently the preoperative diagnosis was not correct. So the electrocardiogram was very important. And another device that was in the operating room sitting beside the patient was a Sanborn pressure recorder. And because you put needles in various chambers to ascertain what the pressure was, and that would give you many times the answer to your diagnostic uncertainty.
So there's a few key things to take away from this short video. One is that a lot of the diagnosis was made there in the after the patient's chest was open, where they're taking needles hooked up to a pressure transducer, measuring the pressure in all 4 chambers to determine if there were ASDs and VSDs. Amazing that you're doing that right on the spot. The other thing is that Earl Bakken's brought to the University of Minnesota. Earl was an electrical engineer that trained at the University of Minnesota. He had started a company called Medtronic in 1949. It was a equipment repair company. The university subcontracted Medtronic to repair the equipment at the University of Minnesota. And then when they, Dr. Lillehei and others wanted an electrical engineer there 24/7 available during these procedures, Earl came and was present during these procedures to make sure that all this new sophisticated electrical equipment now would maintain function during these critical cases. However, it was Halloween 1957. There was a bad electrical storm in the Twin Cities. All the power went off in the Mayo building, which meant the hospital, the preclinical research labs, but also the intensive care unit. And a patient being supported by one of these then portable pacemakers, which is plugged into the wall, the power went out and died. And that was pretty devastating for all the team. And so then that's when Dr. Lillehei asked Earl Bakken to make a battery-powered backup. So again, these were the portable systems. To move the patients with these portable systems, the story is they use 100-foot extension cords, unplug one, plug in another, and keep moving them. And so Earl thought, well, I'll just get a car battery and an inverter, and I'll put it on this cart to solve that problem. So he went back to Medtronic at that time, which was his brother-in-law's garage. And there's Earl working in this garage, or Medtronic at that period of time. This is probably university equipment from the hospital, and came up with a solution.
And that's when I looked up a circuit for a metronome in Popular Electronics magazine of that time. And one of the home projects in there was to build a little box that would put clicks on a loudspeaker the way a metronome sets clicks for timing music. And it's interesting that the metronome has the same rate range as normal heart. You can adjust it from 50 up to 100 or 150 or so pulses per minute. So I plagiarized that circuit, in effect, modified it a little bit so it'd be a 1 millisecond pulse, and put it in a little box with a 9-volt photo flash, a battery, and a little neon bulb to show you if it was pulsing, and brought it over at the university with Vin Scott, and we tried it one day on a dog in the animal lab. I hadn't necessarily built this to be used on humans, but the next day I came over to the university and this was attached to a little child. And I asked Walt about it, and he said, well, he wasn't going to risk another power failure and losing a child to that. And that's what.
So again, takeaways from this. They did a preclinical trial on this. We, again, Dr. Iles and myself went over to the university archives, saw the files of Dr. Lillehei, found a picture of that one preclinical study they had performed on a canine, did open heart procedure, caused heart block. They taped the wearable pacemaker that Earl built, and there's the wire coming out going into the right ventricle. That same day, then Dr. Lillehei took it off this dog and brought it upstairs, hopefully sterilized it, and they were keeping a young child alive with it. They didn't do anything wrong. Again, the FDA started in 1938, but it didn't cover medical devices till 1976. And this is also compassionate use of this medical technology. So again, just to kind of finish up with the last few slides here about Doctors Bakken and Lillehei. The U gave Earl an honorary doctorate in medicine. He had this philosophy of ready, fire, aim.
And try to teach them a little bit of your kind of philosophy that I call ready, fire, aim. You got to do something before you can find out how to fix the problems that might come out.
So these two guys were doers for sure. After the era of pacing, and Dr. Lillehei did a lot of research on pacing as well, worked with Earl. They joke in some of these videos that they were two good buddies that happened to both be Norwegians. That the next era was valves, and a lot of the different valves, as I mentioned before, were developed at the University of Minnesota as well, and implanted in the late 1960s. Again, important, we have a pediatric heart surgery program in Masonic Children's Hospital as part of the Department of Surgery, led by Dr. Massimo Grasselli and we have Sami Saeed has joined him as well there. Very different OR from what I showed in those early videos. We have available imaging, x-rays right there present, and they're doing very complex procedures, even with, for example, like the Berlin heart system, keeping these children alive for years prior to transplantation. Again, down in the basement of the Mayo building, after the era of Dr. O'Hilla and others, Professor Richard Bianco began doing a lot of work with him and others and really developed experimental surgical services, which is really a premier place to do preclinical research worldwide. And he really led the way on doing a lot of the preclinical research on all different types of cardiovascular devices, but more specifically cardiovascular valves. Again, our visible heart laboratory is in there now. So this is as the history continues. And again, we do translational research and anywhere from target delivery of drugs to the Visible Heart Project to extracorporeal circulation systems and many others. So again, Dr. Lillehei was a legend at the University of Minnesota, known as the father of open heart surgery. After his passing, his wife Kay established and family established the Lillehei Heart Institute on October 23rd, 2001, which is still ongoing, important institution at the university today. Earl passed away a couple of years ago. Again, great friend of the University of Minnesota. To honor his contributions to biomedical engineering and the cardiovascular field, we have the Bakken Surgical Device Symposium. The next one is in September 2020. Earl had some great philosophies, as did Dr. Lillehei and Dr. Wagenstein. You know, we get ready by continuous learning and education. We get ready by feeding our minds with information. We get ready by developing a belief in our institution. We get ready by thinking in unstructured ways and chasing impossible dreams. And again, one of my favorite quotes from Dr. Wagenstein is, "The only limits on your achievements are the limits that you place on your own imagination." And we should all take that to heart as we move forward into the next era of cardiovascular surgery and cardiovascular repairs. Again, a lot of this information you can get in other resources, but we also, on our own Visible Heart Lab, we have the Atlas of Human Cardiac Anatomy. We have a brief history there that you can look up as well. And with that, I'd like to thank you all. And again, here's some additional references. A great read is The King of Hearts by Wayne Miller. I would see Wayne Miller. I definitely recommend that you do that or read that. And the book by Daniel Gore is also a fascinating read. Thank you very much and take care.